Okay, so these are my objectives: to discuss the diagnosis, pathophysiology, and treatment of cyclic vomiting syndrome, and also describe the endocannabinoid system and the diagnosis and management of cannabinoid hyperemesis syndrome, which we also call as CHS. Okay, so we'll start with a patient case. This is a 70-year-old woman with a history of anxiety who presented with episodic abdominal pain, nausea, vomiting since she was 10. She has a history of sudden onset of repeated vomiting lasting 1 to 2 days associated with mid-abdominal pain. It was recurrent and lasts about 20 to 30 minutes, and this would occur monthly. Only some episodes would occur with a migraine headache, and her mother had a history of migraines. She was seen when she was younger by pediatric gastroenterologists. They did an upper endoscopy, celiac serologies, they were negative. They diagnosed her with abdominal migraine. They placed her on metoprolol and escitalopram. She improved for a few years, but then when she was in 10th, 11th grade, her symptoms got worse because she started getting more stressors and more demand for what she had to do with her time. A lot of more schoolwork. She was trying to get in a good college. She was playing club volleyball. She saw a holistic provider who diagnosed her with a, quote, chemical imbalance and recommended dietary changes and supplements with no relief of her symptoms. She was admitted to the hospital at age 17 with a very severe episode of abdominal pain and repeated vomiting that started at 5 in the morning. She smoked marijuana to help reduce the vomiting. She would fall asleep, and then she woke up, and then she would have this repeated vomiting and pain. Marijuana was used once per week for 2 to 3 months. It helped decrease her abdominal pain. It helped her eat, increased her appetite. She would use hot showers transiently to reduce symptoms. On exam, she had mid-diffuse abdominal pain, tenderness. Her labs included amylase, lipase, abdominal ultrasound, CT scan, MRCP, which was negative. She was started on amitriptyline while she was in the hospital, and also prescribed oxycodone that she tried not to use very often. She had no bowel movement for the past 3 days while in the hospital, while on pain medication, and she had been on Colace. She did have a history of constipation when she was younger, in the 5th, 6th grade. Used a dancitron, the 5-HT3 antagonist, occasionally, but would vomit. She quit club volleyball, and she decreased her school workload. So this is the diagnostic algorithm for chronic nausea and vomiting. So you always start at the top left, start with symptoms. This is chronic or recurrent nausea and or vomiting, history, physical examination. As we typically do with these functional motility disorders, we ask about alarm features. Because if you ask about alarm features and they're present, you may do a different diagnostic workup. Then you ask, so if you're going to do a workup that's upper GI, endoscopy, blood work, and other tests that you think are important to have, and if there's an abnormality, you treat it. Now, when you're doing the history, you want to always see if there's a temporal relationship with any drug or medication, and if it is, and typically you're looking for marijuana with nausea and vomiting, then you eliminate it, and it's only if you eliminate it and they have symptom improvement that you can say they have cannabinoid hyperemesis syndrome, but I'll go over that in a little bit. One thing that you want to determine if someone says they have nausea and vomiting is you want to make sure it's really vomiting and not really regurgitation. And vomiting is really more of the contracting the abdominal wall muscles, bending forward, just more projectile, forceful emesis as opposed to effortless regurgitation. And if someone has effortless regurgitation, particularly if they swallow back the food, bring it back up, swallow, even while they're eating, and they spit it out when it starts tasting acidic, then they can have rumination syndrome, which would be treated differently. But in patients that they have this very typical episodic vomiting, they can meet criteria for cyclic vomiting syndrome or CVS. If they don't meet any of those, they can just have what is called chronic, or we used to call it functional. It's probably going to change to chronic nausea and vomiting syndrome. So there was a study done in the English-speaking countries on the prevalence of chronic nausea and vomiting syndromes that you can see here. There's a little bit higher prevalence in the United States, but you can see functional nausea and vomiting on the left, and then chronic nausea and vomiting and cyclic vomiting syndrome. So it's, about somewhere 1 to 2% of the patient population. This is the Rome-4 criteria for cyclic vomiting syndrome. They have criteria also for pediatric patients. It's a little different by the duration and the number of episodes. But the Rome criteria for CVS is stereotypical episodes of vomiting. It's not just one vomit, one emesis. It's just repetitive that you see this, and they can't really control it. I actually had a patient in clinic years ago that developed one of these episodes in clinic, and his eyes turned red, and he just couldn't stop vomiting, and I admitted him to the hospital because the sooner you control it, the shorter the duration. You have to have at least 3 discrete episodes in the prior year and 2 episodes in the past 6 months, and they have to be at least 1 week apart. In patients with more functional chronic nausea and vomiting, that's something, it could be even daily. The CVS is really these episodes that are separated in time, and in between the episodes, there's an absence of vomiting. Now, they can have some milder symptoms, and I tend to see patients where they still have some abdominal pain, but they're not really having the vomiting episodes. One supportive remark on the diagnostic criteria is they could have a history or a family history of migraine headaches. So I always ask that. So this is really the typical 4 phases of CVS. You have this prodromal phase. They get a little more weak, diaphoretic, nausea. If a patient can try to stop the episode, then it's really the best time to try, whether they take a Dancertron or something like that. And then they get in that emetic phase with this intense emesis, multiple episodes. It's really hard to stop it once that gets started. So to me, the preventative measures are always the better way to go. And then they have that recovery phase after a few days. And then they get this resolution. And in between the episodes, they don't have any vomiting. So it's usually in the early morning hours, and that's why they were linking it to CRF, which is corticotropin releasing factor, which is released from the hypothalamus, stimulates the pituitary gland to secrete ACTH, and then the adrenal gland to secrete cortisol, and has the diurnal rhythm. And about the early morning hours is when you have a peak. And CRF can decrease gastric emptying and induce vomiting, particularly in stress. The duration is hours or days. The attacks are longer, more frequent in adults than in children. Children are a little shorter. A third, like I said, could have migraine headaches. They could also have psychological symptoms. It's typical to have a family history, particularly the mother, for migraine headaches. And symptoms are triggered by stress. But what's interesting, it's not just something that's more of a negative stressor. It could be a happy event, like a birthday party. It's something that just kind of excites the system that can trigger a CVS episode. Also, when they don't sleep very well, they have some sleep deprivation. Maybe they're studying for finals, or there's some kind of URI or infection. Anything that kind of perturbs the system, puts it at a lower threshold, it triggers their symptoms. So this is really the pattern of cyclic vomiting versus chronic vomiting, where the cyclic is really these yellow peaks, and the chronic is lower level of vomiting, less episodes, but just more frequent. So, and people have been in my clinic and who've seen a patient that I have seen with CVS-like symptoms know that it's really a group of disorders. So you can start off with cyclic vomiting, but you also often see abdominal migraine in the history, and then they also have migraine headaches. So these 3 entities often go together. Now, they may not have all of them, but you have to think about when you see cyclic vomiting that it's part of the cluster that are related of disorders of abdominal migraine and migraine headache. But cyclic vomiting and abdominal migraine, that gets better as patients get older. When they get in the mid-20s, late 20s, it starts getting better. So for abdominal migraine, and the Rome-5 criteria is actually going to develop a criteria for abdominal migraine in adults. So this is really what's used in children. So they have to have all of the following at least twice. These paroxysmal episodes of intense acute periumbilical, midline, or diffuse abdominal pain lasting 1 hour or more. It should be the most severe distressing symptom, but it really isn't very long. The episodes are separated by weeks to months. The pain's incapacitating, interferes with normal activities. A lot of these patients, they fall on the floor when they have the abdominal pain. And it's associated with 2 or more of the following: anorexia, nausea, vomiting, headache, photophobia, pallor. After appropriate evaluations, and symptoms cannot be fully explained by another medical condition, and they meet the symptom criteria, they could have abdominal migraine. So CVS, this was the Rome-4 chapter on gastroduodenal disorders, and they included CVS in it, and they had a pretty long list of diagnostic testing. I probably don't do all of them, but you really think about the patient. Do they meet the symptom criteria? More aggressive testing if they have bilious vomiting, if they have abdominal tenderness, there's any neurologic findings or signs, and just worsening progressive pattern. You do, of course, a comprehensive chemistry panel, look for hypercalcemia, hypothyroidism, and Addison's disease. So some people will do that Cortison stim test. Consider drug screening if you think about CHS, but the patient is denying the use of cannabis products. You do upper endoscopy, small bowel x-ray, CT or MRE that can evaluate gastroduodenal disease, look for a partial or small bowel obstruction, and then a CT scan of the brain to exclude for brain lesions. If these tests are normal, you could consider a gastric emptying test, but studies have shown that if you get a gastric emptying test in between CVS episodes, there can actually be rapid gastric emptying. It's not usually delayed. It's either normal, it could be rapid. If the severe symptoms persist, then you could consider antroduodenal manometry. Most people don't do this, but you're assessing for enteric neuropathy or myopathy. But it's really that if it's normal, that it's more helpful. Esophageal pH testing can also be considered if you're trying to exclude vomiting as an atypical presentation for GERD. And then you consider these rare conditions like porphyria. It's really gives you, really you can diagnose by classic history. So you just think about the different treatments for the different phases. Often we use a tricyclic agent. We use something called Cyproheptatine, which has a antihistamine effect and some serotonergic effect, a beta blocker. Sometimes people start using anti-epileptic agents. And then really just to treat the patients, often they have to abort it. If they're at home, they try to take hot showers, take a Dancitron, any antiemetic. A lot of times it helps put them to sleep if they're taking a antihistamine. But otherwise, when you get into the hospital, you really have to give them IV fluids, antiemetics. Sometimes they get pain medication if they're having abdominal pain. You're just really trying to abort the episode and as quickly as possible. So I put here the preventative treatment, and I put in bold what I typically use. So it's really a cocktail that you use. Typically use a tricyclic antidepressant. I find that for upper GI disorders, you have to use a higher dose than lower GI disorders. And they don't really often get constipation like you see in lower GI. So you start at 10 or 25, but I usually start at 25. I use amitriptyline if I'm not really worried about constipation, and it has more antihistamine effect. But you can use disipramine or nortriptyline. And then you increase the dose. I often get to 50 to 75 milligrams, which is higher than I use for the lower GI symptoms, even up to 100 milligrams. But they usually need that higher dose. You can start a beta blocker and usually use propranolol. I usually use this short-acting. You start at 10 milligrams. You can move to 20, even up to 40 BID, which to me is high. So I usually use 10 to 20 BID. If I can't use tricyclic agent, then I use mirtazapine. That has good efficacy for the upper GI disorders. And I usually start at 15 milligrams, but it depends on the patient. If you want to start at 7.5, move it up to 15 and then 30. Often you don't have to go to 45 milligrams, but you usually have to get to 15 to 30. And then I usually add a histamine 1 antagonist. Cyproheptatine is the classic one. They use this a lot in children. You give it at bedtime. It only comes as 4 milligrams, so I start 4 milligrams. They usually can sleep for the first few days, then they start waking up, and then you just increase it to 8 milligrams. When I'm going to start tapering off the medications, I usually take off the beta blocker when they're doing better in histamine. The key medication you have to keep is the neuromodulator, the tricyclic or the quadricyclic, like mirtazapine. You can use anticonvulsants like topiramate. You can try an NK1 receptor antagonist. This is harder to get. It's expensive, but you can try that if it's affordable, or if you can try to get that. There is a little bit of data, but not a great data on mitochondrial supplements like L-carnitine, coenzyme Q10, or riboflavin. So CVS in the past, and I don't know if this is the current thinking, is that it can be transmitted through mitochondrial DNA. And so that's why I think they're focusing on mitochondrial supplements. And mitochondrial DNA is the only DNA that we get from our mother. So there's no contribution from the father in mitochondrial DNA. Now, always the challenge is it CHS or is it CVS? But the fact of the matter is that a lot of CVS patients take cannabis, and they're taking it to reduce their nausea and vomiting, but they could be self-medicating for psychological symptoms. So many CVS patients actually report to using cannabis or some alternative treatments, and they're trying to avoid emergency room visits because a lot of times they just think that they're drug seeking. They don't really like going to the hospital or the ER. But there's increasing emergency room visits and costs for vomiting with those who have cannabis use disorder. Cannabis use is reported in 40 to 80% of CVS patients, so it is common. 21% are regular users, which is classified at least 24 times per week for the past 6 months. Only a small percentage, that's 8.7% of cannabis users, actually meet criteria for cannabis use disorder, and there's a certain validated instrument called the CUDIT. And cannabis use was significantly higher in patients with CVS versus functional vomiting. And the majority of heavy cannabis users reported that abstinence from cannabis for at least 1 month did not resolve their symptoms or vomiting. So they'll say, that's not the cause of my symptoms. But really, they're stopping it for too short of a time. And I'll show you the recommendations from an expert group in a minute. But there is psychopathology and particular anxiety, and that may lead to them using a cannabis, and that they could provoke them to getting not so much CVS, but for getting cannabis hyperemesis syndrome. So this is an updated map and also some information on medical and recreational marijuana. In the dark green, you see the states that have legalized marijuana, not just for recreational use, for medical use, and the light green is where it's legalized for medical use. And the other states is where they haven't decided on this at all. But this is the most, cannabis is the most commonly used federally illegal drug in the United States. Many individuals use this. Gosh, I can't read the slides. It's really 3 in 10 who use marijuana have marijuana use disorder. And for people who began using marijuana before the age of 18 will have more risk for developing marijuana use disorder than if they started when they were older. And marijuana use can affect different parts of the brain responsible for memory, learning, attention, decision-making, coordination, emotion. Using marijuana during pregnancy can increase risk for complications. So if someone is pregnant or breastfeeding, it's advised not to use marijuana. So the endocannabinoid system means there's ligands that act on the CB1 and CB2 receptors, and they're part of the system. So if CB1, CB2 receptors, CB1 receptors are mainly in the central nervous system. There are some in the periphery. CB2 is in the central nervous system, but more of them are in the periphery. THC acts on the CB1 receptor. CBD does not act directly on either receptor, but it can enhance the activity of THC on CB1 receptors, and as well as the some activity on the CB2 receptors. And CBN acts on the CB2 receptors. So this is a slide I've shown before. I think it's a nice review paper, but basically we have CB1 receptors in the brainstem region and also in cortical regions, and the brainstem region where the area postrema and the nucleus of solitarius tract, that's all of what is called the vomiting center. That controls a lot of the nausea and vomiting. But if you act on a CB1 receptor, that will reduce the serotonin that's released in the synapses, and serotonin acts on 5-HT3 receptors, and that causes vomiting to occur. And that's why 5-HT3 antagonists are used for vomiting. And if you act on the CB1 receptor, like with cannabis, you'll reduce the serotonin that's released, act less on the 5-HT3 receptor, and that's why it is thought to have an antiemetic effect. There's also endocannabinoids and CB1 and 2 receptors in the GI tract. They're on immune cells, the epithelial cells, the enterochromatin cells, and enteric neurons. If you if you act on CB1 receptors, that actually will slow down motility, less so with CB2. But it's thought that these endocannabinoids and the CB1, CB2 receptors are involved in pain and also inflammation and permeability. So I want to talk now about cannabinoid hyperemesis syndrome. It was first described in 2004. This is a syndrome of cyclic episodes of nausea, vomiting, abdominal pain. with chronic cannabis use, frequently confused with CVS. It's more in young adults and long history of cannabis use. Delay of several years in the onset of symptoms preceded by chronic marijuana use. So this is important. In their history, they're usually on marijuana for a prolonged period of time before they develop the CVS symptoms. So it's not that they had CVS and they start using marijuana. So you really want to differentiate that. Daily marijuana use is characteristic. Often they're using it multiple times per day. So this is longer use and much more frequent use. And standard antiemetics are often ineffective, like even ondansetron. So the Rome criteria for CHS is really very similar to CVS. The only difference is they'll have relief of their symptoms if they stop the cannabis use. The pathophysiology is not really clear. It hasn't been studied that long. It's thought that, cannabis now is much more potent, so the patients are being exposed to just really higher, more potent amounts of THC. There is a biphasic mechanism of action. This is the one thing that I would try to remember from this talk. Lower amounts of cannabis, marijuana, will have an antiemetic effect. You go to higher doses, prolonged use, you have a pro-emetic effect. And that's thought to be due to more toxic metabolites from the cannabis plant. If you're using this, there may be change in the CB1 receptors. You could even downregulate them, so they have less of the antiemetic effect. There's probably some genetic predisposition of the way this is being metabolized that may link and predict who will get it. And then stress can induce this as well by releasing THC from adipocytes, and it could also affect the CB1 receptors and also endocannabinoids. There was a systematic review that showed that there's limited data on differentiate CVS and CHS. And really, the patients, again, use it multiple times a day. They've been on it for at least a year of cannabis before they start getting symptoms. And so it's really high doses. This is the also important thing to remember. You don't really know if someone has cannabinoid hyperemesis syndrome unless they stop the cannabis for at least the duration of 3 cycles or episodes of CVS. So if they're having an episode every 6 weeks, they really have to be off of it for 5 months to know that you're really reducing these recurrent episodes. And compulsive hot water bathing, you could see it in CHS, but you can actually see it with CVS as well. So it's not really pathognomonic for CHS anymore. There's small studies. These are different agents used for CHS. Yesterday, I was telling Rahul that I prescribed capsaicin cream for the first time yesterday, and a patient has, kind of an overlap of CHS and CVS. They're small studies. So basically, when you treat CVS or CHS, that when you get down to the bottom of this simple algorithm, it's really for CHS, if they have it, you just got to stop it. And that is the only way that you're going to get them off. Now, what I do often is I will put them on some neuromodulator or treatment for like CVS to get them to be able, or for anxiety, to get them to be able to get off the cannabis and do it gradually. Otherwise, they can't get off of it if you're not giving them some treatment. Same with opioids. If you want to get someone off opioids, you have to give them some treatment for their pain. Otherwise, they keep taking the opioids. So she was diagnosed with CVS. She had that spectrum of abdominal migraine, CVS, and migraine headaches. Her marijuana use was lower than typically used for CHS, but she still uses it once a week when she gets nauseous. We increased her amitriptyline gradually to 50 milligrams. She actually went to 75, went back to 50. This helps really keep her in, quote, remission. Cyproheptatine was used because she also had insomnia, and that helped her, and it also helped to decrease her GI symptoms. She uses ondansetron. The moment she feels any nausea, she uses it. You can give them the oral disintegrating tablet. They don't even have to take it with water. Some patients don't like the taste, but you can do that so that you can start right away. She needed stress management. She also got cognitive behavioral therapy. This was also for her anxiety. And she got referred to the integrative GI program practitioners at UCLA. When she got some more constipation, just gave her PEG. She returned with improved symptoms. She had some residual abdominal pain. She couldn't tolerate the higher doses of amitriptyline, so I switched her to duloxetine, which is a pure SNRI, which helped reduce her pain, which she liked better. Now she's 20 years old. Overall, she's doing well. She's in college. milder, well-controlled symptoms. She really came in now, when I see her, looking like a different person, more mature, more understanding how to manage her symptoms, less anxious, and it was, good to see that. So to summarize, CVS is a brain-gut multifactorial disorder with overlap with abdominal migraine and migraine headaches. It has a very distinctive pattern, and you really can use preventative or acute care measures. CHS typically occurs with a long history of heavy use of cannabis. It's due to downregulation of the cannabinoid receptors and loss of the anti-emetic pathway, and sustained cessation of cannabis is required for the diagnosis and also relief of vomiting.